Good morning. Today we're going to discuss the details of the guideline for the treatment of endocarditis. If you noticed, the guideline was already posted in your blackboard with the most important content already highlighted in yellow. Um, Even though you could see that the guideline is from 2005, this is the most updated information from the American Heart Association. We already went through the Duke's criteria and we discussed the major and the minor criteria for the diagnosis of endocarditis. If you see here in the guidelines says that the diagnosis of infective endocarditis is very straightforward when you have the manifestations of major criteria, in addition to the Osleria manifestation, which is bacteremia or fungemia, evidence of active valvulitis, peripheral emboli, or any immunological or vascular phenomena, such as embolies or vasculitis. In other patients, remember that this could be completely absent. Okay, so in addition to that, remember that diagnosis of infective endocarditis is based on the presence of either a major or minor criteria based on Duke's criteria that we already discussed in the prior video. So go ahead and review again the criteria for Duke's, which is very important for your examination and for clinical practice. Remember that the most common microbiology encounter in endocarditis is Streptococci viridans. The major diagnostic test weight was given to only three typical echocardiography. So when you do echocardiogram, when the major criteria mentions the echocardiogram, remember that we discussed already that if there is any presence of a mobile mass attached to any valvular leaflet or any mural endocardium, thrombi, or any abscess or any new dehiscence of a valvular prosthesis, that's a major criteria. Remember that minor criteria could be fever, could be any emboli event, could be any vascular phenomena, intermittent bacteremia. Here again, you have the Duke's criteria, the prior criteria, and modified criteria. Remember that you need to have two major criteria and one minor criteria, one major criteria and three minor criteria, or five minor criteria in order to have the diagnosis for endocarditis. And I actually tag a comment right here that this is a very important information to know. Okay, so two major criteria, one major criteria, and three minor criteria, or five minor criteria to have a definitive diagnosis for endocarditis. This is a very high sensitive and a specific test, so it is very, very accurate. I'm basically scrolling down to show you the most important information in the guideline. In addition, serological tests such as PCR and set rate, even though the American Heart Association is trying to include this serological test as major criteria, still is being a debate and remain as minor criteria. So PCR and set rate remains as minor criteria because it has a very low sensitivity. The diagnosis of endocarditis must be made as soon as possible to initiate therapy. So as soon as you have a very high suspicion of endocarditis based on clinical picture, even though you do not have a complete definitive criteria by Dukes, you should start antibiotic therapy. In cases of high suspicion based, for example, on because the patient is injection drug abuser, because the patient has a history of prior endocarditis, or because there's a presumption of endocarditis before blood culture results are available. If it's a very high suspicious, go ahead and start. Identification of vegetations or incremental vascular insufficiency, mostly regurgitation by echocardiogram, um, often completes the diagnostic criteria for infective endocarditis. So even though the Dukes criteria is very high specific and sensitive, if you have a very high suspicious of endocarditis based on the Dukes, go ahead and start. But don't forget that Duke's criteria is very highly specific. So this clinical diagnosis has to be in the conditions when you have a very, very high risk. So never start treatment just because you have low suspicions of endocarditis. If you really have a high suspicious due to clinical symptoms and you are um, guiding yourself through the Duke's criteria, go ahead and start treatment. Again, I highlighted here high risk echocardiographic features include large mobile vegetations, don't forget that, valvular insufficiency, or any perivalvular extension secondary to ventricular dysfunction. Here again is highlighted and the importance of uh, transthoracic echocardiogram versus the transesophageal echocardiogram. So remember, echocardiogram is central for the diagnosis and management of infective endocarditis. So if you have an oscillated intracardiac mass, vegetation, any annular abscess, any prosthetic valve dehiscence, any new valvular regurgitation, so echo should be performed in all cases where you suspect infective endocarditis. Now, when do you do a transesophageal echo versus transthoracic? So when the imaging is difficult or the window is poor, when for example, when do you think the window for echocardiography is poor in patients that have obstructive lung diseases such as asthma, COPD, chronic bronchitis, any prior thoracic surgery, morbid obesity? So instead of doing thoracic echocardiogram, you should do transesophageal. If the transthoracic echo is negative and you still have um, clinical suspicious of endocarditis, go ahead and do transthoracic. If the transthoracic show vegetation, then you should do transesophageal. Even though when you already see vegetations, it's very, very unlikely that the transesophageal echocardiogram will give you a different result. Remember that transesophageal echo is more sensitive and more specific than transthoracic. This echocardiograms, either transesophageal or transthoracic, could give you a false positive when there are valvular abnormalities prior to the endocarditis. What are the features for patients that have high risk of endocarditis and might need surgery because you're expecting a complicated course? Basically, when the vegetations are large, when there's severe valvular insufficiency, when there is pseudoaneurysm or valvular dehiscence or perforation, or and most commonly when the patient has um, CHF in conjunction with endocarditis or as complication of endocarditis. So you diagnose the patient with endocarditis, you started treatment. this is no more to highlight that the patient who had an initial TTE or transthoracic echocardiogram negative and the diagnosis clinically is highly suspicious, you should consider TEE. Any patient after you start antimicrobial therapy, you should repeat the echocardiogram. So all patients who have experienced an episode of endocarditis remain at high risk for recurrent infection indefinitely. So that's the reason why you should follow the patient with echocardiography when they had prior endocarditis or recently finished a treatment. Now, when do you need surgical intervention? When, again, vegetations are large, when there's a prior embolic event, when there is aortic or mitral insufficiency with signs of ventricular heart failure, CHF, when there is perforation or rupture of the valve, when there is dehiscence, when there is a new heart block, or when there is a large abscess. Every time the patient has these features, including CHF decompensated, they're high risk for mortality. That's the reason why surgical intervention should be followed by antimicrobial therapy. Now, this is what I explained in the prior video. If we followed recommendations for different microorganisms, including streptococci, viridans, bovis, staphylococcites, and others, you would see that the majority of the choice for antibiotic have something in common. The main treatment for endocarditis is penicillin G, 12 to 18 million units in 24 hours, or ceftriaxone, 2 grams, 1 dose, or ceftriaxone plus gentamicin. Even though vancomycin could be used, I highlighted here that vancomycin therapy is recommended only for patients unable to tolerate penicillin or ceftriaxone. So all the time, your penicillin or your ceftriaxone rocephin, 1 dose is enough. If you're using penicillin G, it has to be for at least 4 to 6 weeks. Now, if we discussed patients are resistant to, relatively resistant to penicillin, even though the treatment is exactly the same, penicillin G, these are the patients that have a native valve endocarditis, they don't have prosthetic valve, or ceftriaxone plus gentamicin. So it's exactly the same as the prior treatment. You have different choices here. Remember, ceftriaxone plus gentamicin. Here is ceftriaxone plus gentamicin, but the initial treatment, if you're not allergic to penicillin, should be penicillin G. Here again, vancomycin therapy is recommended only when you're unable to tolerate penicillin or ceftriaxone. So the first initial choice should be penicillin G or ceftriaxone. Now, if you have a prosthetic valve, you should receive 4 to 6 weeks of therapy with penicillin or ceftriaxone, with or without gentamicin for the first 2 weeks. And again, vancomycin therapy is recommended only if you're unable to tolerate penicillin and ceftriaxone. You need to have that in mind. If it's streptococci pneumonia, minimal 4 weeks of therapy of the same treatment already mentioned. You could also combine any beta-lactam with aminoglycosides, such as gentamicin, as previously stated, ceftriaxone plus genta, and even more if the patient is HIV. when the CD4 counts are greater than 300. Otherwise, the treatment changes. Now, what about this is the prior explanation with the prosthetic valve in patients that have streptococci. Again, penicillin G or ceftriaxone with or without gentamicin, and vancomycin only when the patient is unable to tolerate penicillin or ceftriaxone. So far, you have seen that the treatment is more or less the same. When does it vary? Well, if you have staphylococci in the absence of prosthetic material, the other choice would be, as I mentioned in the prior video, is nafcillin or oxacillin with gentamicin for patients that have penicillin allergy, but this allergic reaction is non-type 1, it's non-anaphylactic. You could use still cephalosporins for 6 weeks with genta or vancomycin. So again, nafcillin or oxacillin with genta if you're allergic to penicillin but non-anaphylactic reaction type 1 hypersensitivity reaction, cefazolin with gentamicin or vancomycin. Prosthetic valve with staph, same treatment. More or less, you could do nafcillin or oxacillin plus genta, or you could do nafcillin, oxacillin plus rifampin. This is exactly the same thing for enterococci, ampicillin plus genta, or penicillin G with genta, or vancomycin plus genta. So if you see, more or less it's exactly the same. You use a penicillin, any type of beta-lactam. It could be penicillin G, or it could be nafcillin or oxacillin or ampicillin, but it has to be combined with gentamicin or ceftriaxone with vanco or vanco with genta. And vanco, remember that only when the first line fails. Okay? So I'm not repeating this because it's exactly the same treatment. Now, what about when you have atypical atypical microbial therapy? Uh, atypical microorganisms such as Haemophilus, Acinetobacters, um, Haemophilus influenza, and other types of Haemophilus. Well, the best treatment for that, even though you could use beta-lactams and also third or fourth generation cephalosporins, you could also use, and this also applies for patients that have allergies to penicillin. You could use Cyvox, you could use imipenem plus ampicillin, you could use ceftriaxone plus ampicillin, but this is only when there is atypicals. In addition, you could use fluoroquinolones in combination with fourth generation cephalosporin. You see, you could use ceftriaxone or ampicillin or Cipro. So what is the most common treatment that applies to all? Penicillin G or ceftriaxone. You could also combine it with gentamicin, and remember vancomycin only when there's a failure to penicillin and ceftriaxone. Now, what are the complications of endocarditis? And remember that this was an indication for surgery. So basically, patients that have CHF, they should go valvular surgery to reduce mortality. This is very important to know. In addition to that, other surgeries, as we discussed, indications will be valvular dehiscence, perforation, rupture, fistula, abscess. This further explained. So basically, the decision to operate is driven primarily due to the severity of CHF. So if a patient has a New York classification, class 3 or class 4, that you should have already gone through that. So basically, this is the patient that have signs and symptoms with the minimal ADL activities, and this is a rest. Now, other complications will be embolization, embolize, and 65% to 90% of patients that have embolized belong to the central nervous system. So, no DVTs, no pulmonary emboli, even though it's part of the minor criteria. The major and most common type of thrombotic event is at the level of the CNS. Now, this embolic risk decreases during the first 2 weeks of therapy, and there's a controversy to start anticoagulation therapy or not. That we will see this later. So again, it's very controversial. You could go ahead and start anticoagulation if the patient has other risk factors and associated with the virtual triad. Otherwise, aspirin will be enough. So how do you manage this patient as an outpatient? Even though it's not indicated, okay, because it's very cost effective, um, you need to, it is cost effective, but it involves agencies going to the patient's house, monitoring the PIC line for infection, um, treatment regimen, usually, nurses um, following this patient. It could be done outpatient due to economic pressures. That we need to reduce hospital stays. So after the patient is being 1 week or 2 weeks in the hospital, patient could be sent home with home therapy, um, continuing antimicrobial therapy intravenously through the PIC line. The problem is that patients could develop complications with this, um, such as arrhythmias, recurrent fever, CHF, and neurological event. So regular visit by a home infusion nurse who carefully monitors the patient for early detection of this complication is necessary. Regular visit, the patient has to see the practitioner every week to monitor these symptoms as well. Now, follow up as part of this of outpatient therapy is necessary for surgical treatment. So every time a patient has a surgical treatment or medical treatment before completing antimicrobial therapy, this patient should be followed. And in addition to that, remember, after 2 weeks of therapy and after completion of therapy, the patient should have at minimum a transthoracic echocardiogram. In addition to that, if the patient obtained endocarditis due to IV drug abuse, then you should refer this patient to a special program. Educate the patients of the signs and symptoms of endocarditis in case of recurrence, because remember, this patient has a high risk of recurrence. Um, Make them aware of the need for dental evaluation, because this is one of the sources to obtain endocarditis. So how do you care for the patient after the completion of antimicrobial therapy, which is also important? Obtain a transthoracic echocardiogram. You need to refer the patient in case of IV drug abuse to a rehabilitation center. Educate the patient for signs and symptoms of endocarditis because of high recurrence. Educate them about the need for dental procedures and how to um, have prophylaxis for that, and mention the need for prophylaxis to the dentist. Um, prompt removal of the IV catheter. So the majority of the patients follow outpatient antimicrobial therapy with a PICC line or any type of central line. So after completion of this antimicrobial therapy, discontinue the line because this is one of the sources of endocarditis. Obtain at least 3 sets of blood cultures from separate sites for any febrile illness before initiation of antimicrobial therapy. This means that, remember that even though any high-risk suspicious clinically of endocarditis, even though you should have in mind the Duke's criteria, should be enough to start antimicrobial therapy, at least obtain 3 sets of blood cultures because you need to avoid resistance. So don't go ahead and start antimicrobial therapy when you have a um, low suspicious symptoms for endocarditis. So anytime the patient has a febrile illness and had a history of endocarditis, at least please obtain 3 sets of blood cultures before you initiate antimicrobial therapy. So do not initiate antibiotic just because any fever could be a recurrence. So physical examination of evidence of CHF. Remember that CHF is a high mortality factor associated with endocarditis. So you have to monitor the patient for any type of CHF symptoms, any toxicity to this antimicrobial therapy, and long-term follow-up. You need to again obtain blood cultures for any febrile fever. Febrile illness, echocardiography. You should follow the patient for this. Um, and this is highlighted because it's super, super important to have in mind. So even though high risk clinical suspicious should prompt you to revise the Duke's criteria and start antimicrobial therapy, at least do 3 sets of blood cultures before you do that, because it's very highly discouraged to start antimicrobial therapy for any type of febrile syndrome with an unproved positive blood culture. Now, to finish, how do we start prophylaxis for procedures that patients could be at risk of endocarditis? The American Heart Association recommends antimicrobial prophylaxis for patients at high risk of any adverse outcome from infective endocarditis. Examples of this are patients that have had endocarditis in the past, have prosthetic heart valves, certain congenital heart diseases, in addition to patients that have heart transplant. So most procedures for which prophylaxis is required is for high risk patients that are going to have oral dental procedures, that you're going to manipulate the gingiva, or that, for example, GI or GU procedures or any type of musculoskeletal procedure that you are predicting the patient to have bleeding. So basically invasive procedures. So examples of this would be, for example, dental wise, dental extraction, dental implants, any type of periodontal procedure, root canals, respiratory tract, for example, would be bronchoscopy, tonsillectomy, adenoidectomy. GI tract, even though you might think endoscopy and colonoscopy would be invasive procedure, so far the American Heart Association have not been able to identify any GI procedure that the patient might be at risk for bleeding, unless the procedure is done during the endocarditis period. GI, if the cystoscopy is going to involve any high risk for bleeding, then cystoscopy, but so far the American Heart Association hasn't been able to identify, unless again this procedure is being done during the endocarditis period. So, which antibiotic you should start for prophylaxis of any type of these invasive procedures? Amoxicillin, you could do 2 grams PO. If the patient is allergic to penicillin and is not a type 1 reaction, you could do cephalexin, or you could do clindamycin if the patient has a type 1 allergic reaction. In addition, you could do azithromycin, you could do clarithromycin. So again, for the majority of invasive procedures, if you're not allergic to penicillin, amoxicillin, or you could do also ampicillin. If you are allergic to penicillin and you're not a type 1, cephalexin. If you're a type 1, then clindamycin, or you could do azithromycin or clarithromycin. And that would be the end of this presentation. Thank you.